Bismillahirrahmanirrahim. In this lecture, I will talk about indications for peptic ulcer surgery. Peptic ulcer disease is common with a lifetime prevalence in the general population of 5 to 10% and an incidence of 0.1 to 0.3 per year. Complications are still encountered in 10 to 20% of these patients. We are seeing here complications of peptic ulcers: perforation, hemorrhage, gastric outlet obstruction. Gastric ulcers are also at risk of developing gastric malignancy. Penetration perhaps causes pancreatitis or gastrocolic fistula. I will talk now about indications for peptic ulcer surgery. Peptic ulcer disease was once the most common indication for gastric surgery, but now only infrequently requires operation. We are seeing here gastric ulcers, and we are seeing here duodenal ulcer, gastric ulcer, and duodenal ulcer. Currently accepted indications for surgery in the management of peptic ulcer disease include: the first indication for peptic ulcer surgery is bleeding. Patients with a bleeding peptic ulcer, including rebleeding, are usually managed endoscopically, first-line therapy, or with angioembolization, second-line therapy. In stable patients, we are seeing here many cases of duodenal ulcer bleeding. Bleeding is the most common complication of peptic ulcer disease, with a reported annual incidence of bleeding in the general population ranging from 0.02 to 0.06%, with sample size weighted average 30 days mortality of 8.6%. We are seeing here many cases of gastric ulcer bleeding. Surgical intervention is indicated when a patient fails repeated endoscopic intervention and or becomes unstable, especially for a more than 2 cm ulcer. The second indication for peptic ulcer surgery is perforation. Patients with perforated peptic ulcer causing significant pneumoperitoneum or extraluminal contrast extravasation or signs of peritonitis should undergo urgent surgical exploration. We are seeing here perforated peptic ulcer, and we are seeing here a 5 mm perforated duodenal ulcer on the anterior surface of the first part of the duodenum, and we are seeing here perforated duodenal ulcer. But we are seeing here case of a pneumoperitoneum, air or gas in the subdiaphragm area. And we are seeing here extraluminal contrast. But we are seeing here case of peritonitis. Reported annual incidence of perforation ranges from 0.004 to 0.014% with sample size weighted average 30-day mortality of 23.5%. We are seeing here case of laparoscopic approach for perforated gastric ulcer. But we are seeing here case of perforated peptic ulcer found in the great curvature of the stomach. Although perforation is less common, with a perforation to bleeding ratio of approximately 1 to 6, it is the most common indication for emergency operation and causes about 40% of all ulcer-related deaths. We are seeing here case of perforated peptic ulcer. There is a little role for endoscopic or non-operative management, except that non-operative management may be possible in highly selected patients with sealed perforation confirmed by contrast study. We are seeing here case perforated peptic ulcer found in the great curvature of the stomach. The third indication for peptic ulcer surgery is obstruction or gastric outlet obstruction. Is the least frequent ulcer complication in developed countries. Most cases of gastric outlet obstruction are associated with duodenal or pyloric channel ulceration. Gastric ulceration accounts for only 5% of cases. We are seeing here many cases of gastric outlet obstruction. The fourth indication for peptic ulcer surgery is intractable disease. Intractability as an indication for elective gastric surgery is increasingly unusual. The precise time period after which an ulcer should be considered intractable remains poorly defined. We are seeing here case of gastric outlet obstruction, and we are seeing here case of gastric outlet obstruction. Severe symptoms, failure to heal on medical therapy, including antimicrobials, and relapse while on maintenance therapy or after multiple courses of therapy may indicate the need for surgery. We are seeing here case of a 58-year-old man with a history of intractable peptic ulcer. More controversial and infrequent indications for surgery also include intolerance or non-compliance with a medical regimen, high risk for ulcer complications. We are seeing here case of intractable ulcer in the stomach. High risk for ulcer complications such as organ transplant recipients and those who are steroid dependent or non-steroidal anti-inflammatory drug dependent, and giant gastric or duodenal ulcer, although most of these can be healed with medical therapy. The fifth indication for peptic ulcer surgery is suspected malignancy. Infrequently, surgical management is required for peptic ulcer that fail to heal after twice daily anti-secretory therapy with a protein pump inhibitor for 24 weeks in whom other correctable factors, for example, medication non-compliance, non-steroidal anti-inflammatory drugs, and Helicobacter pylori infection have been addressed. We are seeing here benign and malignant gastric ulcer, but we are seeing here a tubercle malignant of stomach ulcer. Malignancy is rare in duodenal ulcer disease, but surgery may be indicated for chronic non-healing gastric ulcer as they may harbor a malignancy that is sometimes not detected despite extensive endoscopic biopsy. We are seeing here case of duodenal ulcer, but we are seeing here case of benign gastric ulcer and here malignant gastric ulcer. We are seeing here case of malignant gastric ulcer, but we are seeing here case of benign gastric ulcer. I will talk now about surgical options. Surgical options for peptic ulcer disease range from local therapies that only manage ulcer-related complications, that is, bleeding, perforation, or obstruction, to definitive ulcer operations. We are seeing here case of duodenal ulcer bleeding, but we are seeing here case of perforated peptic ulcer, and we are seeing here case of gastric outlet obstruction. In this slide, we are seeing here many types of operation for peptic ulcer disease. For example, for duodenal ulcer, highly selective anterior vagotomy combined with posterior truncal vagotomy. For gastric ulcer, there are many types of operation. For example, distal gastrectomy, subtotal gastrectomy. For gastric outlet obstruction, for example, the operation is highly selective vagotomy with gastrojejunostomy. For bleeding duodenal ulcer, operation partial gastrectomy. For bleeding gastric ulcer, ulcer excision. For perforated duodenal ulcer, the operation perhaps simple closure. For perforated gastric ulcer, operation partial gastrectomy. Generally, the least morbid procedure that will adequately manage the patient's problem should be used in each instance. We are seeing here case of malignant gastric ulcer, but we are seeing here case of benign gastric ulcer, and we are seeing here case of duodenal ulcer. In the end of this lecture, thank you for all.